All right. Well, I don't know if if it's live yet, but I'll go ahead and start. First of all, I want to introduce myself. I'm Tony Campbell from Wells Pharmacy. I've been a pharmacist here for a number of years. Been compounding since 2003, and I'm heavily involved with the production and the compounding and formulation creation for the sterile products here at Wells Pharmacy. I do want to thank you for taking some time this afternoon and listening to this presentation on testosterone injection. And we're going to talk a little bit about complementary therapies for treating low T, or otherwise known as male hypogonadism. So just some things to cover, just so you know what we're going to.
The broadcast is now starting. All attendees are in listen-only mode.
All right, well, welcome, and I want to thank you for taking time today to listen to this presentation on testosterone injection and the complementary therapies for treating low T, otherwise known as male hypogonadism. Introduce myself. I'm Anthony Campbell, pharmacist here for Wells. Been here for quite a few years and have been compounding sterile products since 2003. And with that, I want to jump right into it. And if you have any questions, there'll be time at the end, of course, to ask those. So just to cover some things that we're going to talk about today. So the causes, the prevalence, some signs and symptoms of male hypogonadism, otherwise known as androgen deficiency, specifically in the aging adult. Some lab testing, specifically the treatment options and protocols for injectable testosterone replacement therapy. So we're going to limit a lot of our discussion and protocols to simply the injectable form of testosterone. While there are other routes to deliver and methods to deliver testosterone, we're going to pretty much hone in just on the injectable form. And then we want to present some complementary therapies that are often prescribed with testosterone injections and why they're used and why you would want to use those, sometimes even instead of testosterone. And then, of course, I do want to cover some side effects and adverse reactions that are commonly seen with injectable testosterone. That always seems to be a surprise to some users when they get these reactions, as if they were maybe the only one that it occurred to, or maybe it's the first time that it happened to them, even after years of being a testosterone injection user. So just to get right into it, so we want to define what hypogonadism is, right? So there's two different types, or two different definitions of hypogonadism, and depending on which definition will determine what type of hypogonadism that you would have. So hypogonadism, or primary hypogonadism, is the failure of the testes to produce levels of testosterone and a normal number of sperm due to the disruption of one or more levels of the HP testicular axis. What we're going to talk about today is the other definition, where late onset hypogonadism is associated as you age. And this type of testosterone or hypogonadism is often referred to as secondary hypogonadism. So primary hypogonadism is often associated with low testosterone caused by a failure of the testes to produce testosterone. They often have a normal or even elevated LH or FSH gonadotropins. It's also referred to as, and because of that, it's referred to as hypergonadotropic hypogonadism. So we're going to give most of our attention, if not all, to secondary hypogonadism. And this is the failure of the hypothalamus and the pituitary gland to produce or stimulate enough luteinizing hormone or follicle-stimulating hormone to produce the testosterone. So because of this, it's also known as hypogonadotropic hypogonadism. So specifically, under secondary acquired hypogonadism, we're going to focus all of our attention pretty much on the aging aspect of this. So what do we see with men who have hypogonadism? I'm sure you're all familiar with this, but you know, some of the key symptoms here are the decreased libido, the difficulty with the erections, and the decrease in the early morning erections. The other symptoms that might occur that are not sexually related are the patients will feel lethargic, irritable, depressed, they might have a decrease in their muscle mass, and they might find that their abdomen is getting larger. Some of the physical signs, of course, the obesity, the gynecomastia, those types of things are often seen with or without the sexual symptoms or physical signs. This list right here is, of course, not all-inclusive. There are many more, but these are some of the more commonly seen ones. Some of the associated conditions, of course, this isn't an all-inclusive list either, but just want to impress the fact that, of course, diabetes, hypertension, those vascular diseases are often seen with men with hypogonadism. So if you have a patient who's presenting with symptoms of hypogonadism, it's always a good bet to look at other factors as well as their medications that they're on. You know, drugs like spironolactone can inhibit the DHTs, right? So you get an increase in estrogen. Cimetidine, ketoconazole can exacerbate or cause gynecomastia. The SSRIs, right, they're notable for causing the erectile dysfunctions, the low libido, and among other things. So other things to look at, just other than the symptoms, when I look at the full picture of the patient, you get a full idea of their overall general health rather than just a low T value that might be from you might find from a lab test. So really not here to teach you anything, but I do want to just emphasize the point that as men age, their risk or their percentage, their chance of getting low testosterone levels significantly increases. And this has been demonstrated in a number of studies. One here done in 2001 shows that between 2 to 4 million men in the U.S., I'm sure it's more than that, are affected by low testosterone. Interesting fact is that 5% of these men who are affected are only receiving treatment. So it's a relatively low number. So as the BMI increases of your patient, that's inversely related to your testosterone levels. So patients who have an ever-increasing BMI are more than likely to have low testosterone. And as you age, you can see each decade of life jumps up 10 to 20%. So it's very common from the ages of 50 to 60 and older. I think the study also reported that 1 in every 16 males ages 40 to 80 do have hypogonadism. So it is very prevalent. The study here in 2006 done with men that were over 45 years old who were defined to be have hypogonadism with a total testosterone less than 300. Only 80 of those patients were receiving testosterone. So of all the men that are hypogonadal in that study, less than 10% of those patients were receiving therapy. The increased odds ratio, of course, all the other factors and medical conditions with hypertension, diabetes, increased BMI, COPD, and asthma, those types of things are often associated also with hypogonadism. One of the larger studies done was the Massachusetts male aging study done in 2004, just to show that it is an ever-increasing condition in men, and that 500,000 new cases a year are to be expected. So very, very common, very prevalent in men as they age. So the benefits, I'm sure we're all aware of those, right? The increased energy, the sleep, increase in relief from depression, the increase in muscle mass, the soft fatty tissue, tends to decrease as you build that lean muscle. This has been established in a number of clinical research studies, clinical articles, and the such like that. So the benefits of providing testosterone are well documented and proven. So what do we do to treat this, right? So the first thing, whether you use medication to treat it or whether you do not, the first thing should always be lifestyle changes, right? So we want to promote an active exercise program with aerobic and weightlifting activities, and maybe work with a dietitian to improve anybody who might have poor dietary habits, to help encourage healthy eating plans. So the other thing to do, of course, is decrease your smoking, excessive alcohol use, things like that. Those kind of go without saying. But besides that, if you want to start medication therapy, right, an option would be to simply reduce estrogen levels, right? Because as estrogen increases, testosterone decreases, and as well as your free testosterone. So how do we do that with medicine? So we can do it with anastrozole, letrozole, these types of drugs, right? So these are drugs that are affect the estrogen, right? So estrogen is a primary mediator in the hypothalamus pituitary axis. So they do promote the production of your gonadotropin. So some studies show that by giving these medications, you can decrease your estrogen and increase testosterone without giving any testosterone supplement whatsoever. So it's always a good place to start, being that the luteinizing hormone is the primary messenger to signal the Leydig cells to increase testosterone. The other way you can do this is to increase testicular output of testosterone, and we can do this by simply giving HCG. So this is only effective in the secondary hypogonadism only. So this kind of falls into the category that we're talking about, if you recall from the first few slides there. So what this does is the alpha chain on luteinizing hormone and follicle stimulating hormone are identical to the HCG molecule. So it'll mimic the action of LH and FSH. And what this will do will increase that production, will increase the Leydig cells to produce more testosterone. We can do this pretty much with low doses, anywhere from 500 to 1,500 units, 3 times a week, so maybe every other day injections. So a lot of the studies and the clinical research show that the dose is kind of all over the place. There's really no established dose for this. So you just always want to use, of course, the lowest effective dose. So it's best to start low and then titrate up as needed. So the benefit of this is it does maintain fertility for those patients who do want to maintain their sperm count and their fertility. Another option to increase testicular output is the use of clomiphene. So clomiphene will decrease the estrogen binding, which will in turn increase testosterone production. And the dose for these is 25 milligrams, maybe every other day to begin, and then we can titrate up to 50 to 100 milligrams even every day if needed. And this also does maintain fertility. So most of the time, your last line therapy is going to be testosterone supplementation. So somebody with presenting with low testosterone symptoms, and you've maybe diagnose them as having hypogonadism, it's not always recommended to supplement initially with testosterone, and we'll talk about that in a little bit later in the slides. So we can give testosterone by injection, by topical cream, or gel, or implantable pellets, which is becoming a very popular alternative as well to the injections. A lot of times the injections are a turnoff to a number of people. It's not convenient for them, so they do use an implantable pellet. So just to talk a little bit more about the alternative and complementary therapies, the aromatase inhibitors that we talked about, those will again block the conversion of androgen to estrogen. Kind of the concern here is maybe the risk for osteopenia and osteoporosis, as it does decrease your estrogen levels. Some of the information in the literature says that this should be monitored at least yearly to ensure that their bone density is not declining. The HCG, I think we covered all this pretty much, but this chart on the side here will kind of show you kind of where it acts, if it's above or below the pituitary, and then how it may or may not affect the spermatogenesis. So drugs like the aromatase inhibitors, things like that, those are going to be great. If you want to tend to maintain your fertility, it's not going to affect those. The clomiphene, HCG will be fine with those. So we get right to the injectable testosterone, and we're going to talk about these for a little bit. I think there's a lot of maybe misunderstanding or just some knowledge that's just not there. And a lot of physicians I talk to, they don't really know the difference or even know why they're prescribing any of these esters. They just kind of know that maybe what the half-life is, so they think that that's better or maybe more potent. So we're going to talk about that and how this all works out. So these are all the different esters. There's a couple more that I don't have listed, but 3 of the most commonly used, the propionate, enanthate, and cypionate. specifically are what we do provide here. And that's for a number of reasons. It's just for availability, cost, side effect profiles, adverse reactions that we know with these, as they were commercial products. There's published information, lots of literature on them. So the testosterone decanoate, so I've had a few doctors ask for that, even the undecanoate, just because they see the longer half-life and think, well, I don't have to inject, but maybe once every 2, even 3 weeks maybe. So we're just going to focus a little bit on our formulary, but you can see from the side here that the propionate does deliver a lot more concentration of testosterone when you compare it to something like the enanthate or cypionate, or even the phenylpropionate that you see that's very similar. So while you get a longer duration of action, you do get a shorter, a decline, a spike in the concentration. So the idea is how to balance that and how to work that out so it's best for the patient. So we're going to look at these just a little bit. So esters, right, are a chain primarily composed of these carbon and hydrogen atoms, and they're all the same. All the esters have the same parent molecule. The only difference is at that 17th carbon molecule, there's a chain of esters that kind of go on and on and on and on in your longer ones, the cypionate, enanthate, decanoate. So for it to become active, it has to be cleaved all the way back down to the original molecule. And the longer it takes to do that is the longer half-life that you're seeing. So we'll take testosterone enanthate, for example. So testosterone in itself has a molecular weight of 288. Enanthate, being a long ester, weighs a little bit more. So when we convert that to the total amount of testosterone, we can see that 28% of that molecule is simply ester, and it has no drug in it. So when you give 200 milligrams of enanthate, you're basically giving 144 milligrams of testosterone. So what about cypionate, right? That's a little bit longer. People think, well, that's more potent, and that's true and not true, but you can see that 70% of this is the drug, so 30% is the ester, so you're actually giving a little bit less when you give cypionate. So you take a drug like propionate, which is a much smaller molecule, you do get more drug being delivered in the same amount milligram per milligram basis. So 200 milligrams of propionate will deliver a little bit more total testosterone in the same dose, and that's simply because your ester is smaller, so more of the weight or less of the weight is going to the ester. So what does this all mean, and how can we work it out, when we blend these things? So at Wells, we do offer some blends, ultra test, tri-test, and different variations and percentage concentrations. So how does this relate to the total that we're giving? So in our very popular ultra test 200, 80% of this contains testosterone cypionate. So that means in 200 milligrams of ultra test, we're getting 160 milligrams of cypionate, which equates to 112. Again, with the propionate, 20% of this is about 33. So overall, we're giving about 145 milligrams of testosterone. Something like tri-test, it doesn't matter how you break it down, you're still going to deliver approximately the same amount of testosterone in that dose. So the total amount that you're giving doesn't change, but what does change is maybe the duration that you're giving. So you can see that 112 milligrams of cypionate versus 70 milligrams of cypionate might have a difference, not necessarily in the amount that you're providing, but in how long it has an effect or how long between injections. And we can do this all day with different variations. So I get some physicians who say, well, I want 2 of your long-acting ones. I want you to make a new formula, and I want you to do this with cypionate and enanthate, because that's your 2 biggest, esters. And we're really not giving anything more, actually giving less than something like our ultra test, total testosterone. There's really no benefit. You increase that maybe to a 90-10, and you're even getting a milligram less, just the way that the math works out. So the point to drive home here is, right, adjusting the ratios of the esters has more to do with how frequently you're going to dose than it does with how much total testosterone you're going to provide. So it's very important to balance that ratio, whatever product that you're using, to equate to what the patient's going to need and where his levels and what his goals for therapy are. So your dosing options for your intramuscular injections right? We're going to take testosterone enanthate or cypionate, and they're pretty much identical. There's hardly any difference in them at all. So they're esterified oil-soluble preparations that are supposed to be given with deep intramuscular injections. So typically we see 200 to 300 milligrams every 2 to 3 weeks, and that may be appropriate for some, but I'm going to argue that that's probably not the best dosing option. You'd probably want to do something more along the lines of 100 milligrams, maybe 150 per week. In most patients, I know it's more, it's less convenient to give it every week, but you'll see that you'll get less spikes in therapy. So what happens was you want to test this after 3 weeks with the low serum levels. So what I'll do is you get increasing the dose. I get some physicians who say, well, your levels aren't there yet, so let's increase your dose. Let's increase your concentration. Let's give you a little bit more testosterone. So what this does is it does not prolong the duration of action, but it sharpens the peaks and valleys, right, that you're going to see because you're given more exogenous testosterone. So you get the super physiologic levels initially, followed by these declining levels. So what this does is increases the conversion to estradiol. You get mood swings. You're at greater risk for polycythemia, gynecomastia, all the adverse effects that we don't want to see because you're getting these super high spikes that are peaking very high and then dropping off very rapidly. So a better method might be to provide a lower dosage at weekly intervals. You get a more continuous release without the high peaks and the valleys of the high dosing concentrations. So if a patient reports an adequate clinical response, you really don't need to change the dosage or adjust it, even if you see his blood levels maybe not climbing as rapidly or maybe not to the point that you want them. I know a lot of clinicians will try to go to the middle part or the middle upper part of normal, but you know, if a patient's doing well and noticing difference and they're right in the middle or maybe just below middle normal, it really wouldn't benefit them to increase the dose. There's no proven study to show that the more or the higher his testosterone level is, that you know, there's going to be a positive effect on his overall longevity. So you got to remember it's a reference range, right? So you got it's a pretty broad range too. So you don't necessarily always want to get to the highest number you can. It's really not the goal of therapy. So we want to know about the adverse reactions, right? So this is pretty much a list of every adverse reaction known with testosterone injection. So this is a combination of all the information from the commercial products that's out there, that's been done in all the clinical studies, and the FDA package inserts. So all of these things are possible, although they're very rare if they happen at all in most patients. The two or three that happen the most, of course, are going to be at the localized skin irritation at the injection site, or maybe a rash at the area. Another one that might not be on here is a localized kind of a hard nodule right after you inject. So a lot of these those types of reactions are due to improper injection technique. And I'll get argued back, well, I've been using this for 2 or 3 years and this has never happened, so I have you know, I got a bad product. And you know, that's certainly possible, although it's very, very, very rare. You know, it's less than a 0.000% chance that you're going to get any type of bad vial from us, since all of our products are fully tested and documented to be free of any kind of contaminants whatsoever. So having said all that, these side effects that these patients might see or you might hear about at the site of injection are mostly going to be due to improper injection technique, commonly resulting from, you know, either not giving it IM, not giving it deep enough IM, not using the right type of needle, the right location, or maybe the technique. So it's very important that these needles are long enough, sufficiently long enough to go deep intramuscular, not just to the top of the muscle, where after you pull that needle out, that oil is going to come right back into that subcutaneous space from that hole that you just made from that large bore needle. So a lot of this is the oil leaching back out of the muscle. A way to prevent that is either to apply pressure immediately after pulling the needle out, or alternatively use something called the Z-track injection method. I'm not going to cover it here, but you can Google that, I'm sure, and find that technique and why it's very effective when you're giving a deep IM injection. So all these things need to be considered, as well as the volume that you're giving. So typically no more than 1 ml should be injected IM. It's just not going to hold that much volume, particularly that thick viscous oil. So we do want to make sure that it does stay in the muscle. You're giving a needle long enough to get into the muscle. So I've heard a number of patients who might have a thin, maybe a relatively thin, lean patient going on testosterone, and they might be 6 foot, 170 pounds. So they might need a different needle length. They might get away with a 1-inch needle, as opposed to somebody that might be 5'8", 5'9", weighing 230, 220. So, and the patient's body type, if they're obese, if they're 5'8", 5'9", and obese, there's going to be a lot of subcutaneous layers and tissues and fats there, compared to somebody that might be 5'9", 220, and he's got 5% body fat, but he's just bulked up, right? So all these things need to be considered, and what works for one patient shouldn't be standardized for every patient of yours. So body type is something certainly to consider when injecting these viscous oils. So potential risks, I just got to cover these, right? The only one that really is of concern is the erythrocytosis, which is common with anybody using testosterone injections, as well as the prostate cancer. So there's been a number of studies out there that shows that testosterone therapy doesn't cause prostate cancer. It won't make a subclinical tumor become clinical. It won't start any tumor, but it has been shown to maybe aggravate the symptoms of somebody that might have prostate conditions. So the one that's a big concern, and why we use a lot of these alternative therapies, is the one on the bottom with the testicular atrophy. So this is very common with chronically used exogenous testosterone injections. It's usually always reversible with discontinuation of therapy, but it can be maintained or maybe altogether prevented, using the alternative methods with the HCG or the clomiphene along with testosterone injections. And we do see that used very, very commonly with patients who've been on testosterone for any amount of time. So there's recommended lab testing. So these are just some of the things that you want to get to a brand new patient. You want to test all these things, kind of get a baseline feel for where they are. Specifically, of course, the testosterone. If they, estradiol may or may not be needed. If they have symptoms of high estrogen, then of course you might test for that. Your sex hormone binding globulin, that may be an initial test. It might be a good idea to do that. Otherwise, you can order that, after you get your results back. And if you have some low levels of testosterone, you might want to find out. But it's good just to do all these just at once. So the other one that's really important, of course, is your PSA and your hematocrit levels, just to see where you are baseline. Things like lipid, metabolic, and thyroid tests. If you're one of those physicians that prescribe to do everything once, just all at once, then there's certainly no harm in doing that. But if the patient is otherwise healthy and doesn't look like they're, have any metabolic conditions, there wouldn't be any need to get those lipid, metabolic, or thyroid panels. But it's always a good idea just to get them instead beforehand. So these monitoring parameters, this is mostly here for your reference, just to look at a little bit later if you would like to. And these are some suggested actions that you could take with each one of these parameters. So the monitoring, the prostate screening is, of course, always required for anybody on testosterone therapy. So it's a good practice to get into, to get a baseline picture of your patient for any difficulties they might have, voiding, urinating, history of sleep apnea. You want to get a baseline DRE exam, your testosterone, all those things. And then a prostate biopsy would be indicated if the PSA, was greater than 4, or you have an abnormal DRE. The follow-up, of course, you want to do after a couple months. You want to give it at least 3 months before you change anything your therapy. Kind of give it time to take full effect on the patient. So the evaluation initially should be after 3 months, then 6 months, and then a year, every year to do these. And there's just some recommendations here of things to look for and things to monitor. So the prostate screening. So these things are these indications for biopsy. They're no different from those for men with normal testosterone levels. Just men with hypogonadism may be predisposed to more rapid growth of a tumor. So you just want to be sure that you're following these. So these are recommendations from 4 different places. There's clinical trials, the Endocrine Society, and a couple studies who give the recommendations of when to do a PSA biopsy. So the Endocrine Society Clinical Practice Guideline, right? This is a really good thing to follow. Testosterone therapy is always recommended for all those conditions on the left. However, they're not recommended for a lot of those conditions, all of them on the right-hand side. So just because somebody comes back with a low testosterone level, you don't stick them right on testosterone therapy. You want to look at all those different things, test all their levels, make sure that they're a candidate for this. So this may help you out a little bit. I just put this together for you to kind of use as a guide, kind of a flow chart thing. So you'll see that the only time testosterone is first-line therapy is when the patient has low estrogen and they don't desire to keep their fertility. So that's the only time you want to initiate testosterone therapy as first-line therapy. Other than that, you want to begin with the alternative therapies, see how that affects the patient. Those are always going to be a little bit safer. And then you can add testosterone if they're not achieving their goal, if their testosterone isn't getting out of the low part of the reference range. So this will hopefully help you a little bit. Maybe give you some guidance if you don't have any guidance right now, but hopefully you'll get some understanding of this. And if you have any other questions on the testosterone injections, I'll be happy to take those now.
Thank you, Tony. My name is Jennifer. I am the marketing manager at Wells Pharmacy. Right on the right-hand side of your screen, you'll see a questions box. Feel free to submit any questions, and we can get those answered by Tony right now. And we did have a question roll in, so let me read that off to you, Tony, and see if you can answer it. Now, someone is asking, what have you seen for the length of time patients can stay on Clomid? 1 year, 2 years, or longer?
I haven't really seen anything on how long they can stay on it. I did a lot of the studies that have studied this use. They're not infinite studies, so they do have a definite endpoint. So most of those are significantly longer than 6 months to a year. They might go as long as a couple years, but it all would depend on how well the patient's responding to that. I don't know of any, I haven't read of any reason why you would discontinue it after a certain amount of time in any of the clinical readings or studies that I've read. So if there's not any indication that you're finding in the lab values, there shouldn't be any indication to discontinue that I'm aware of anyway.
Okay, and then someone wants to know, can you comment on testosterone pellets?
Sure, I think that's a great alternative. Personally, I would defer to the pellets if I were looking to get testosterone replacement, and that's just a personal preference because I really am averse to using a 1.5 inch thick bore needle to stick in my muscle. So, having said that, though, there are drawbacks to pellets because as a side effect for testosterone injection would probably only last a week, 2 weeks at the longest. Once you implant pellets, unless you get them cut out of you again, you're pretty much stuck with those for 3 to 4 months of any of those adverse effects. So pellets would be probably reserved for a patient that is well maintained, he's been established. Definitely not a first-line therapy right away. Somebody that's been maybe on testosterone injection for a year or two and wants to transition off, then I would probably, refer them to pellets. I do have another webinar on pellet therapy. It would probably be available on the Wells page, but you can you might be able to look at that, and it does cover some things in there about when pellet would be indicated. So that's just my personal opinion on it. I think it's a great thing for those patients who don't want to do needles, but keep in mind that the once they're in. So.
Thank you. And I know some of you are asking if a copy of the slides will be available. For everyone who registered for the webinar, we will go ahead and email that out before the end of the day, so you'll have a copy of this. And let's see, another question that came in. Now, how long is the typical treatment? 20 weeks, is that too long?
No, I think that's probably the minimum that you'd want to go. I think when you're using testosterone injection, you give at least 90 days. I know that's about 12 weeks, but that's the minimum. So 20 weeks, you're looking at close to 6 months there. So, you certainly can give it that long if you're just, trying to give them a boost for a little while. If they need chronically used, and there's certainly I know patients who've been using testosterone for multiple years as injection therapy. So the minimum at least 3 months, 3 to 6 months. As far as how long you can provide it or how long you can do it, I think that's going to be kind of a patient-determined factor.
Now, someone said, can you address testosterone replacement in patients with heart disease, specifically MI and CABG?
Right. So those are your patients that are going to be kind of tricky. So they are kind of, giving testosterone in those patients, you're really going to have to dive into their clinical picture and look at that. There's a lot of clinical research out there done on that. I do have a very good study that looks at all those different indications that patients have, and gives you guidance on those. They are guidelines, from the Endocrine Society. So, I can include that on the web page as well. And it's a very lengthy article, so I wouldn't have time to really cover it here, but it would provide some insight anyway into the different disease states, covering anywhere from cardiovascular to diabetes to everything in between. So that might be useful reading for those patients with those questions. But certainly, those patients with the cabbage and previous MI. I don't know that it's entirely contraindicated. It's going to be a case-by-case patient thing that you're going to figure out, but there are certainly risks that need to be weighed in that, sure.
Okay, and what is your opinion on SC injections? A lot of experts seem to advocate it.
Yeah, so that's something that came up in the last few years. There's a lot of clinicians maybe prescribing to that mindset, and I think there's even a commercial product I think that's in development in the last year or two that's it's an auto pen, and it uses testosterone enanthate to be injected subcutaneously. So the results of that study have shown to be very beneficial as far as to patient compliance, patient acceptance. The testosterone levels, work out fantastic. So in regard to is subcutaneous injection effective, yes, I think that the clinical research has shown that it actually is effective. In regard to actually administering it, it's very difficult. Remember, that study was done with an auto pen, so there's a precise depth on which that's injected, and only that depth. We give these patients very fine needles, And while they may be, 8 millimeters or even ½ inch in length, intended for subcutaneous space, there's a lot of other factors to consider on, physiologically each patient if they're actually administering that, correctly. So the other drawback would be the viscosity of these oils are very thick. So pushing them through a very fine needle, say even a 27 or 30 gauge needle, it's going to take some amount of pressure and take some time to actually administer that dose. You start injecting these oils subcutaneously, you have to consider a lot of the increased risk maybe for the dermal side effects and maybe the localized injection site reactions that you might incur, since a lot of these are due to the oil injected intramuscularly that kind of leaks back out into that sub-Q space. So a lot of it may have to do with the amount that you're injecting, as well as the needle length, the location you're injecting. But certainly, as far as being effective, subcutaneous testosterone has shown to be just as useful as intramuscular and greatly more accepted among the patients.
Now, someone wants to know, would you suggest using HMG over HCG?
HMG?
Mm-hmm.
Well, I gotta admit, I'm not really, versed on that particular component. I haven't really looked for studies on that. I can only recommend maybe what's been used clinically for the HCG, but it's hard to say without having any knowledge of kind of what the clinical research has shown. But certainly, just from the research done on the HCG, I can be a strong advocate for that. But without having any data, I can't really say anything in regard to the HMG.
Okay, and can women take testosterone to increase libido, and what was in the pink pill?
Okay, so yes, women can take testosterone to increase libido. And the second part of that question, what's in the pink pill?
Yeah.
Not sure what, are they referring to something that we prepare? Or is this something that's commonly known as the pink pill?
I think it's something commonly known as the pink pill.
I can't say I'm familiar with the pink pill. I would probably guess that that's something to do with testosterone, but I don't know what the pink pill is personally. So if they know what's in it, I might be able to give some direction. But sorry, I'm not familiar with that term.
Okay. Now, someone said they have a patient that's usually that's using testosterone cypionate 200 milligrams and a 0.2 ml IM 3 times a week. Is there an easier regimen using a different testosterone formula, such as once weekly?
Okay, so he's using, you have to say that again, 200 milligrams?
No, 200 milligrams of testosterone cypionate, 0.2 ml IM 3 times a week.
And this was a female?
They actually did not specify.
That's a pretty low dose for a male. Well, you're getting, I think, 40 milligrams 3 times a week, so that's not too terribly bad. But I think that. I mean, that to me that sounds like maybe a little bit too frequent for the cypionate. I think if you were maybe using something with a shorter ester, you would use it 3 times a week. The cypionate, you could probably use a lower dose twice a week, or maybe just bump up the dose a little bit and give it twice a week. But 3 times a week for the cypionate, I mean, it really depends on how well the patient's responding and what their blood levels are. If they're getting great results, then certainly keeping it there would be fine. But if it's a matter of convenience for the patient and they want to change it, then certainly you could divide that up and do something like 60 milligrams twice a week as opposed to 40 of it 3 times a week.
And someone wants to know, can the hypogonadism be reversed with testosterone?
Well, the effects of it will. I guess it depends on what the cause of hypogonadism is. So, if you remember from I think the second slide, it did show that there's a lot of causes here for secondary hypogonadism. So, depending on what condition they have, it's probably not going to be treated and reversed, but you can certainly treat the symptoms. So, things like the Prader-Willi syndrome or the Bardet-Biedl syndrome, those types of things are not going to be completely, healed and walk away without ever having to use it again. As you age, those are things it's just what your body, does. You just produce less and less of it. So what we're doing is we're really not going to treat it for a certain amount of time and then be done and then walk away. These will be things that will probably have to be continued to maintain the benefits and the effects of this.
Now, relative DHT response of injection versus gel versus pellet.
Relative DHT response?
Yeah, of injection versus gel and versus pellet.
Okay, so I think a lot of those, I think that there's some information I have on the topical form of it, maybe not being quite as effective as the injectable. I have to, it was in the fine print of one of these readings, but they're going to have certainly an effect on your DHT levels. But if you're got a patient with the high estrogen, that'd be something to look at. But the relative effect would be, dependent on the dose, the frequency. Maybe it would be a little bit different effect with the pellets, versus the cream, versus the injection. Certainly with the injection, you're getting a big exogenous dose all at once versus, pellet, which is prolonged over the course of 3 or 4 months, versus a cream, which is going to typically be delivered in very low concentrations daily. So if I had to say the relative effect, of those, I would say that the injection would have considerably more, followed by the pellet, and then of course the topical. But a lot of that would depend on a number of factors with, the application site of the cream and things like that, and the ability for the drug to penetrate through that particular patient's dermal layer. So certainly without question, there would be a higher concentration of testosterone with the injection. So there'd be a little bit more profound effect initially, at least.
Now, what dosage of anastrozole would you recommend to go along with testosterone treatment?
Right. So those are all listed in the slides. You can look back on those for the dosage recommendations. So a lot of that's going to depend on your patient, but certainly you can start those doses. I think at 0.25 milligrams. Either daily or not daily, but well, you could, but typically start off with 0.25 milligrams, 3 times a week, and maybe work up to even 0.5 milligram every other day. So you really got to look at how well it's affecting the patient and how well that they're responding to it. So remember just to always start at the lowest dose and then titrate up. So the old saying goes, start low, go slow. So you can do 0.25 milligrams 3 times a week, again, anywhere up to 0.5 milligram, every other day. I've had a few physicians prescribe, the 1 milligram tablets, and they'll give that maybe 3 times a week or even twice a week, and it was a little bit too much for them, so they had to cut their dose back. I had a couple of prescribers even cut it back even beyond that because it is a very, very potent drug. So certainly starting at 0.25 milligrams, isn't going to be not effective. It's going to have a pretty profound effect even at that low dosage.
Okay, and do we compound the long-acting 3-month formulation?
No, for injection, no, there isn't going to be any injectable that's going to last 3 months that we do here. You'll remember from the slides that even the longest ester had a half-life that was only a couple weeks. I'll see if I can get to it if you'll still see it. So even if we prescribed or compounded the testosterone undecanoate, your half-life of that is only going to be 15, 16 days, at best guess. So something that an injection that would last for 3 months is very unlikely.
Okay, well, thank you so much, Tony. We do have a few other questions that came in, but we do have to wrap it up. For any additional questions, feel free to email myself. You will get an email from me shortly on the recording of this webinar. So any other questions, feel free to email them in and we will go ahead and answer them. And for anything else, we'll give it another minute if anyone has any other questions, but thank you so much for attending. We appreciate it.
Thank you all.
Thank you.